Hello everyone. So today I am going to talk about hereditary angioedema, and so just starting with the definition. So angioedema is actually characterized by a localized self-limiting swelling. So it's unlike nephrotic syndrome, wherein the swelling is more generalized, or any other cause of swelling because of kidney disease. Non-inflammatory nature is a very characteristic feature of angioedema, unlike cellulitis, wherein the swelling is more inflammatory, painful, and it is basically the edema of the subcutaneous and or submucosal tissue, and it's caused by increased leakage of fluid from the capillaries into the layers of skin and mucosa. So how do we actually classify angioedema? The first one is mast cell or histamine-mediated angioedema. It's actually much more common than the bradykinin-mediated or the hereditary angioedema. And then there are certain causes wherein the cause is still not identified. So hereditary angioedema can be classified into three types, and I'll come to that in a minute. While acquired C1 esterase inhibitor deficiency is actually common in patients with in adult patients as compared to children. So you don't see this entity in children, but in adults you see if the disease onset is after the age of 40, you have to consider lymphoproliferative disorders, autoimmune manifestations like SLE, and sometimes if the patient is taking an enalapril or any other ACE inhibitor, so that may actually cause acquired C1 esterase inhibitor deficiency. So how do we actually differentiate between bradykinin-mediated and histamine-mediated angioedema? So these are some of the characteristic clinical manifestation of both the diseases. The histamine-mediated angioedemas have an abrupt onset of the disease. The duration is less than 24 hours. There are no triggers in patient with histamine-mediated angioedema, and there are no prodromes. While some of these features are actually present in bradykinin-mediated angioedema, and common one is actually hereditary angioedema. You see the itching and urticaria is a very characteristic manifestation of histamine-mediated angioedema, while you don't see this feature in bradykinin-mediated angioedema. So this is one of the most important features by which you can differentiate the two conditions. And then there are certain more features by which you can actually differentiate the two diseases. One point that you must always note that the histamine or mast cell mediated angioedema almost never causes laryngeal edema and never causes death because of laryngeal edema. So this is another very important point. So type 1, type 2 and type 3 are the cause, these are the three different types of hereditary angioedema. So the type 1, the C1 inhibitor protein is low. In type 2 it is normal but the function is abnormal, and type 3 both protein levels and function are abnormal. So type 3 is actually very rare. The pathophysiology is actually complicated, but one we can remember that the bradykinin is the main molecule which is implicated in the pathogenesis of hereditary angioedema. So these are some of the characteristics. Most patients have onset in the childhood. They may decrease in the older age group, but not always. And usually these attacks are unilateral, and they may be associated with prodromal symptom. And one of the most important clinical manifestation that I mentioned is that there is no itching, no urticaria, and no erythema. So these are some of the clinical photographs of the patients with hereditary angioedema. You can see these patients present like these swelling episodes. Autosomal dominant history is seen in up to 80% of the cases, and it's one of the very characteristic clinical manifestation of the disease. So you can see this family who comes from Odisha, and you can see the several family members died because of the disease, and several family members who are still affected. So this typical history you will never see in patient with histamine-mediated or allergic angioedema. Now, abdominal symptoms are very common, and when these are present, this is more characteristic of bradykinin-mediated or hereditary angioedema, and some of these patients may actually be subjected to surgery. This we have already talked about. Laryngeal edema is a fatal complication, and it may be fatal. It used to be fatal in approximately 30%, but now the mortality has reduced. So this is very important that we may consider that the HAE is rare, but if you look at the global prevalence and the population of India, there are approximately 30,000 patients with the disease in India at present. So far, I think we have not been able to diagnose more than 1,000 of these patients, but there are more than 29,000 patients with this disease still suffering. So this is the simplest evaluation algorithm. You have to first measure C4, and if it is low, then this is a very high likelihood of being HAE. So then, depending on the C1 inhibitor levels, then you can characterize whether it is type 1, type 2, or type 3, or acquired causes of angioedema. If the C4 level is normal, then angioedema is less likely, but it is never ruled out. So C4 is approximately 80 to 85% sensitive in diagnosing HAE. So even during attack, in 20% cases, the C4 level can be normal in HAE. So this is the treatment is divided into treatment of acute attack, prophylaxis, short-term and long-term. But one point that you may note is the glucocorticoid, antihistamine and epinephrine are not effective for treatment of HAE. Now these are some of the treatment options. Now I would say that for, about a month ago we had just availability of fresh frozen plasma for the treatment of acute attack, and this is to be used in life-threatening situations. But now we have the availability of an Indian manufactured plasma-derived C1 inhibitor, and two more brands are likely to be available. So this is going to change the management of this disease drastically. Now, short-term prophylaxis, I won't go in detail, but this is to be used whenever there is a known trigger. So for example, a surgery, a dental procedure. So then you can use short-term prophylaxis. And this slide just shows the way you can modify your drugs to give a short-term prophylaxis. Now the long-term prophylaxis, we have a low threshold because we don't have very good first-line treatment options and they're not easily available. So we give them attenuated androgens and tranexamic acid. And now I think the C1 inhibitor replacement will also be available very soon. So this is my concluding slide. I would say that suspicion is the key, and to suspect these cases, C4 is a very simple screening test, and the first line treatment options are now available in India, and they're likely to be accessible for most people.